Before we discuss the primary CNS tumors, we would like to know that the CNS has secondaries like any other part of the human body, and the primary source of the secondary of the CNS tumors are in male the bronchogenic carcinoma, and in female is the carcinoma of the breast, followed by the GIT and the renal system. Now we will discuss the classification of the primary CNS tumors. There are different types of classification of the CNS tumors, but the most accepted and simple or easy to remember is the classification according to the embryonal origin of these tumors. Now first we have the elements normally present in the central nervous system. First we have the neural tube derivatives giving rise to glial cells. First of all, the glial cells give three types of cells. We have the astrocytes, oligodendrocytes, and the epidermocytes. Now, for the astrocytes, it gives usually rise to a tumor, which is the astrocytoma, and the astrocytoma we have four grades, grade 1, 2, 3, and 4. Grade 1 and 2 are considered low-grade astrocytomas, while the malignant type, the grade 3 and 4, which are high-grade astrocytomas. And the second type of cells is the oligodendrocytes, giving rise to oligodendroglioma, which has a special predilection for the frontal lobe, and it's in the younger age group, and the clinical presentation is usually is that of seizure or epilepsy, and has special characteristic of calcification, which can even be seen on plain skull x-rays. And the final type of cells, we have the epidermocytes, which gives rise to four types of tumors. We have the ependymoma, we have also low-grade and high-grade ependymoma, we have the choroid plexus papilloma, and from the name you can tell it's a benign tumor, and we have the choroid plexus carcinoma, which is a malignant one, and the colloid cyst. Now the other type of the neural derivatives, we have the neurons, giving rise to medulloblastomas, ganglioneuromas, and gangliogliomas, and the final type of cells, we have the pinealocytes, which are the pineal body cells, giving rise to pineocytomas, which are the benign, and the pineoblastomas, which are the malignant. Now we have the other type of cells, which are from the neural crest derivatives. First of all, we have the Schwann cells, and as you know, the Schwann cells are usually envelop the axons of the neuron, and we have an example of that. We have the acoustic neuroma from the vestibulocochlear nerve, and we have the neurofibromas. The other type of cells, which are the arachnoid calf cells, and you can tell from the name, the arachnoid, it's the origin of these cells are from, or these tumors is from the arachnoid layer of the meninges, so it gives rise to a tumor which is known as the meningiomas, and the meningiomas are fortunately more than 95% are benign tumors, and they do not invade the cerebral tissue, they only compress it. They don't invade it. Only the malignant types, which is less than 5% fortunately, invades the brain tissue. And finally we have the melanocytes, which gives rise to melanomas. Now, besides the neural tube and the neural crest derivatives, we have other types of cells, which are first the connective tissue, which gives rise to primary cerebral sarcomas, and we have the reticular endothelial cells giving rise to primary CNS lymphoma. We have the vascular cells giving rise to hemangioblastomas. We have the glomus jugulare cells giving rise to glomus jugulare tumors, and we have adenohypophyseal cells, which gives rise to pituitary adenomas. And of course, you know the adenohypophyseal cells, it means the pituitary gland, and the pituitary gland usually they are benign tumors. The pituitary adenomas, they are benign ones. The clinical presentation is usually that of hormonal disturbance or visual symptoms because of the close relativity of the pituitary gland to the optic tract. So we have the other type of the embryonal remnants, which are not normally present in the neural tissue and the CNS. We have the ectodermal derivatives. We have two types. We have the craniopharyngiomas, and we have the dermoid and epidermoid cyst. And we have from the notochord, which gives rise to choroidomas, and from the adipose cells like lipomas, and from germ cells we have the germinomas, and from all three germ layers we have the teratomas. Now, what are the clinical presentation? The most common clinical presentation of CNS tumors is progressive neurological deficit, which is about 68%, and usually it's a motor weakness in 45%, followed by headache in 54% and seizures in 26%. Now, we will come to divide the tumors according to their anatomical position. The clinical presentation will be divided according to the position of the tumors, whether supratentorial tumors or infratentorial tumors. So, with the supratentorial tumors, first we have signs and symptoms due to raised intracranial pressure. We have either from the mass effect of the tumor and or edema, which is associated with the tumor, or blockage of the CSF, which is less common. Sometimes the tumor is a third ventricular tumor which obliterates the pathway of the CSF, and we have the focal deficits, which arise either from destruction of the brain parenchyma by the tumor invasion, or compression of the brain parenchyma by mass and or pertumoral edema and or hemorrhage inside the tumor. And we have compression of the cranial nerves. So all these three, the destruction of the brain parenchyma and the compression of the brain parenchyma or compression of the cranial nerve, gives rise to focal deficits. And we have also headache. The other clinical presentation is the seizures and the supratentorial tumors, and of course this type of the seizure will be variant according to the site of the tumor. We have mental state changes like depression, lethargy, apathy, and confusion. And we have symptoms suggestive of transient ischemic attack or stroke due to occlusion of a vessel by tumor cells or hemorrhage into the tumor itself. And finally, the pituitary tumors either give rise to endocrine disturbances or pituitary apoplexy or CSF leak. Now, for the infratentorial brain tumors, we have signs and symptoms of increased intracranial pressure due to hydrocephalus. As you know, the tumors in the infratentorial compartment will eventually compress or obliterate the pathway of the CSF due to the fourth ventricle or the cerebral aqueduct. So we will have headache, nausea and vomiting, papilledema, gait disturbances, ataxia, and vertigo and diplopia. So now we will have signs and symptoms indicative of mass effect in various locations within the posterior fossa. So we will have lesion in the cerebellar hemisphere may cause ataxia of the extremities, dysmetria, and tension tremor. And you know, the cerebral hemisphere controls the ipsilateral side of the body. So these signs and symptoms, the ataxia and dysmetria and the intention tremor, will be on the same side of the tumor. The right is for the right and the left is for the left, unlike the cerebral lesions. And we have lesions of the cerebral vermis, and as you know, the vermis controls the axial movement of the body, while the cerebral hemisphere controls the movement of the extremities. So for the lesions of cerebral vermis, we may cause broad-based gait and truncal ataxia. And finally, brainstem involvement usually results in multiple cranial nerve and long tract abnormalities. As you know, most of the cranial nerves are originating from the brainstem and the cerebellopontine angle, and the long tract abnormalities, which means spasticity and increased or brisk reflexes. Now we have headache, which is a very common symptom with brain tumors. Why do we have headache? So headache may occur with or without elevated intracranial pressure, and equally present with primary or metastatic tumors, and it's described by being worse in the morning. Why? Do you know during sleep at night the respiratory rate will be decreased, and then the PaCO2 will be elevated and the PaO2 will be decreased. So when you have a raised PaCO2, the brain will become more edematous beside the edema which is produced or the mass effect of the tumor itself. So the headache will be described worse in the morning, and this is the explanation. And the headache will be exacerbated by coughing, straining, or bending forward. Why? Because these maneuvers increase the intracranial pressure, and it's usually associated with nausea and vomiting, and the vomiting temporarily relieves the headache. Why? When you have a headache and you will have the vomiting, during vomiting there will be hyperventilation. The patient's respiratory rate will become increased. in any case of vomiting. So this vomiting will make the CO2 will be washed and the PaCO2 will be decreased, and the PaO2 will be elevated and decreases the brain edema, and the headache will improve. Why do we have headache with brain tumors? The brain itself is not pain sensitive. This is a very important point to be considered. The brain itself is not pain sensitive. So why do we have headache? It's either due to increased intracranial pressure from the tumor mass effect, hydrocephalus, mass effect from associated edema, mass effect from associated hemorrhage, or due to invasion or compression of pain-sensitive structures, which are the dura mater, the blood vessels, the periosteum. Or secondary to difficulty with vision, the patient may have blurring of vision, diplopia, double vision. All these visual symptoms or difficulty with vision will lead to headache, and it's sometimes due to extreme hypertension resulting from increased intracranial pressure, which is part of Cushing's strike. You know, in any case, when we have a tumor or hematoma intracranial or any cause of raised intracranial pressure, we will have actual Cushing's strike. Cushing's strike means hypertension, bradycardia, and irregular respiration. So sometimes extreme hypertension from Cushing's strike will cause the headache. And finally, the cause of headache could be due to psychogenic or psychological causes.